Thank you very much. So now you know what the problem we're trying to deal with is. It's pretty simple. It's a series of incredibly complex issues that go across all society and the planet. Now we'll save your questions, write them down, remember them. We'll have a brief question and answer session at the end. I want to introduce the second keynote speaker, Emily Mendenhall from Georgetown. She's a medical anthropologist and Provost Distinguished Associate Professor in Science, Technology, and International Affairs. She really pushed forward this theory of syndemics, which she's going to talk about today. She's written a number of books, including a forthcoming book from Cornell University Press on rethinking diabetes that talks about the greater impacts with infectious disease and NCDs, syndemic suffering, and anthropological perspectives on global mental health. She won the George Foster Award for practicing medical anthropology from the Society for Medical Anthropology. So it's a great honor to welcome Emily to the podium.
Can I walk? Being quite vertically challenged, I'll walk around. It's really nice to see all of you today, and you know, you did. Oh, let's get a mic. Oh, so I can't. Okay. No, well, you could. Yeah. You can use the mic. Okay, this is just easier. It's really nice to see all of you today, and you did exactly what I was hoping you would do. So I feel really privileged to be able to jump in to this conversation because, as an anthropologist, I'm not going to throw a lot of big charts about morbidity. We know multiple morbidity is really important, and you set the scene so perfectly. I'm going to go deeper and think somewhat using a different theoretical lens, and also share a story as we do in anthropology, and dig a little deeper into these in-depth experiential dimensions that we're talking about today. Can I just see hands of who has read this, the Lancet Syndemic series that I led in 2017? Okay, and who's familiar with syndemics? So some, okay, good. So what are syndemics? Syndemic is a term that looks at synergies among multiple factors in a cluster of two or more epidemics within a population. And it really brings together a formulation for thinking about the things that Tolu mentioned in the last talk. And I have to make this point in part because Rachel's in the room. Syndemics are really building on these ideas from epidemiology, thinking of what is an epidemic, a disease moves through a population. What is a pandemic, a disease moves across the world, across borders. An endemic, a disease exists and remains and recurs within a population. A syndemic fundamentally looks at clustering, but not just of diseases, but also social and political and ecological factors that drive them. And I have to make the point here that syndemics are getting a lot of attention, and I want to be very, very careful that they are interpreted and applied in the way that they were intended. So syndemics are related to epidemics, not pandemics. They're looking at locally driven factors that drive clustering of diseases. And it's so important to look at these as differential and regionally impactful because historical and social and political factors drive the clustering. And that differs from place to place. And as you probably know, as an anthropologist, that's very important to me. So there are three driving kind of rules. So when you think about what is a syndemic, First of all, before I go through the rules, the reason why syndemics matter and why using this term matters and why we've been pushing it so much and we're so thrilled to engage about this term is because it moves across disciplinary boundaries and it enables all of us to put on different hats and converse about what this convergence means. So what is a syndemic? It's two or more diseases that cluster within a population where there's some sort of interaction, biological, psychological, social, and where there are social or structural factors or ecological factors. People have been writing a lot, and we've been having a lot of conversations with my team at Georgetown about ecological factors that are driving, how climate change is driving the clustering of syndemic. So, for example, as mosquitoes are living at higher altitudes, there's more a risk of malaria and HIV infection, for example. And this is from the model of a syndemic that from the paper Merle Singer led. from the Lancet series that basically shows how it's really this interaction with the clustering and the drivers that come together to create a more complicated health experience than any disease or social problem would alone. So this idea comes from medical anthropology. The first paper that mentions any syndemic is 1992. The more comprehensive one was 1994, led by critical medical anthropologist Merle Singer. And it's important to talk about this here because it was originally from deep critical ethnography at the Hispanic Health Council in West Hartford, or in Hartford, inner city Hartford, Connecticut, that was looking at HIV. And he was trying to really understand the complexity of HIV that they were seeing in the inner city. And he found that by looking at HIV, you cannot understand it without looking at violence and without looking at substance abuse. And together, I mean, I've heard him talk about how he used to sketch on napkins what was happening and talking about synergies and epidemics and how they all interact and coming up with syndemics. And it's really, really important to take seriously all these levels of interactions when we're thinking about health and disease. So the outcome, and I say this again and again, but the outcome is the syndemic. It's not the diabetes, or it's not the HIV infection. It's not the substance abuse. It's not the violence, but it's the interaction. And that's really important to do. And it really builds on all the things that you were saying earlier. So it's a nice framework to think through. I was writing a dissertation on embodiment until I came across this paper while I was mid-dissertation, and it just it just made so much sense to me of what I was seeing in Chicago. I spent 5 years at Cook County Hospital studying diabetes, and as I was studying diabetes, I found that women were talking about social trauma, violence, sexual, physical, emotional violence, and how this was embedded in depression, in anxiety, and in their diabetes. And so I ended up looking at the rich epidemiological literature on the bidirectionality of depression and diabetes and how violence and trauma were so closely embedded in these women's lives. So my first book, Syndemic Suffering, really digs into this. So as you can see, the syndemic is the interaction that is so fundamental to understanding why they have higher mortality and morbidity than others with diabetes. We know that there may be the similar rates of acute depression among people across income groups with diabetes, but among low income groups, people who have chronic, untreated, unrecognized depression, there's much higher rates of morbidity and mortality, and this is one reason why. It is a syndemic. It's much more complicated than just a comorbidity. So then I went to work with Dr. Reddy and his team at PHFI in Delhi, and then I worked in South Africa and Kenya, and I was able to study what does diabetes look like across contexts. What does diabetes look like? As we're seeing, there was an earlier paper that Dr. Reddy actually published in 2007 looking at a socioeconomic reversal of diabetes. So I was asked to come and dig into the stories around diabetes and what that looks like. So I had an opportunity to work there, and after there I went to South Africa. And then you can see this is from the paper I led in the Lancet that looks at how in the general population, each of these 4 conditions is much higher among low-income urban populations, and that we're seeing clustering of these conditions within the same populations. So I am actually, well, I'll talk a little bit, I'll jump back and talk a little bit about the framing for this, because I want to jump into the story so I have time. Do you know how much time I have? Since it's about 10 minutes till the... Okay. Well, so what I found in rethinking diabetes is when we look at diabetes across different contexts, it is a very different illness. Partly in this book, I'm arguing that these global narratives of diabetes linked to different food systems and changes across the globe is very important to recognize, but actually when it sits in a population, when diabetes is experienced and embodied, it's very much syndemic, and understanding these syndemic interactions are really important because diabetes is not the same condition, and it needs to be treated differently and understood differently from place to place. Another argument I make here and in a paper that I just published with a colleague in social science and medicine about diabetes in the Somalia region of Ethiopia is that there are different interactions of food and nutrition and even wasting with diabetes in this population. And that leads us to understand what is the psychophysiology of trauma and crisis and hunger and stress that's fueling diabetes. There's a number of papers that are coming out that are looking at different types of diabetes. And it's important to recognize that. Now, when I went to South Africa after working in Delhi for a year, I found that there was this really interesting phenomenon that actually pushed me to think about syndemic interactions in a very different way. Because what I found is that people didn't want to tell people that they had diabetes, because for two decades people had been saying, or faith healers had been educating people, you know, HIV is just like cancer and diabetes. And I've hence done another project on cancer, and people try to hide their diagnoses because what they think when they reveal that they have diabetes or cancer, it's code for HIV. So there's a really interesting social contagion of stigma linked to this experience of diabetes and cancer in this context. So that's another interaction that actually prevents people from seeking care in these contexts. It was interesting. We found this in both Johannesburg and Nairobi. And you know, these are smaller studies, not longitudinal, but it's important to recognize what that means. So I'm going to share just one story from my book and from my work. I've conducted hundreds of narratives around the world about people living with diabetes. And this shows the complexity of living with diabetes and HIV in Nairobi, a woman who resides in Kibera. Esther, a Kikuyu woman of 52 years, sat in an open-air waiting room outside of a specialty clinic for patients with type 2 diabetes at a public hospital near Kibera, Africa's largest slum. Esther rarely sought care at a public hospital clinic because she resided in a neighborhood far from the center of Nairobi, Kenya's capital. She traveled across town because few public diabetes clinics were available in Nairobi, and Esther worried that her diabetes was causing her to feel sick. But sitting in close quarters with the other specialty patients as she waited to see the doctor made her worry. She knew from years of HIV education and from losing her siblings, husband, and co-wife to AIDS that tuberculosis posed risk to her body, as her HIV caused immunosuppression. The specialty clinic waiting room served people with multiple diseases, including diabetes, cancer, and tuberculosis, that required complex medical treatments. AIDS patients had a separate building, PEPFAR funded, nearby. The hacking patient who sat next to her made her worry about her own risk of infection. In addition to comorbid diabetes and HIV, Esther suffered from bouts of malaria and typhoid in the past year while struggling to manage her severe depression. Although she was trained as a community health worker and received some counseling to deal with the loss of her family members to HIV, Esther's depression was severe and at times disabling. Esther grew up in a rural area and lost her father at a young age. As a result, the family lost their ancestral land rights. They moved to a coffee and tea farm to live and work in the fields. Esther only completed 5 years of free primary education before her mother drove her to work in the field full-time. Money and food were scarce. Although Esther's mother remained in the rural areas, Esther left for the city to escape deep emotional pain. She nursed 6 of her siblings to their deaths due to AIDS. She explained that her siblings were infected with the virus before antiretroviral therapy was widely available. Eventually, Esther too discovered that she was HIV positive. After the initial shock of diagnosis, Esther sought training to become a community health worker and to help people suffering from HIV and AIDS. She was paid by a European NGO a meager salary to walk through the community and raise awareness and care for those who were sick. All the money she received from this meager stipend was redirected to buying food for those she served. During this time, Esther had gotten married and had 4 children. But after 15 years, Esther's marriage dissolved abruptly as a result of an infidelity. She took her children with her to Nairobi, first settling in Kibera and then moving to a neighboring slum. One of the most pressing issues in her new environment was insecurity and gun violence that fostered chronic stress. As many women do, Esther felt these social experiences deeply within her body, linking them to wounds in her stomach. But Esther explains how she sought counseling and eventually accepted this situation, redirecting her energy to serving those in need. 6 years after Esther was diagnosed with HIV, she was then diagnosed with diabetes. This diagnosis occurred when she was received testing to begin routine antiretroviral therapy, or ART. She also dealt with herpes while on ART and faced a new diabetes diagnosis. Now, Esther said that diabetes was a shock for her, not because of the diagnosis, but because of the cost. She stated, "They only give us HIV services and treatment for free. Other diseases, such as diabetes, are paid for by the patient, something that is making my life difficult because I can't afford these services." She takes diabetes medication on and off, but she can't afford it and skips diabetes medication. Esther wove a complicated story between diabetes and HIV. She explains how her diabetes caused her CD4 count to drop and caused her to need ARVs earlier than she might have otherwise. She said, the advantage of HIV is that these ARVs are available, but for diabetes, it's hard to get medication when no one has money to buy the drugs. She also described the inability to buy new foods for diabetes care to be an extraordinary stress. She said, I wish diabetes could be affecting the rich because they can afford these special meals. On the day of the interview, Esther had been told that she needed to begin taking insulin injections. She spoke very clearly, however, to explain that it would be impossible to take insulin. How can you keep insulin without having electricity or a fridge? I think the story unpacks this very much biomedical or social epidemiological and even epigenetic model, which is integrated here by Richard Holt, who has written with many other epidemiologists on how we understand diabetes and depression. And the story unpacks this external environment and the complexities driving these conditions, but is a much larger epidemiological epigenetic story over generations in the way that we can understand these complexities. And it's important to kind of think about this model undergirding this really important story and how it then becomes interactive in some contexts with HIV, but not every context. And I wanted to end, it's 2:00, so I wanted to kind of wrap up, but end by thinking about what does this look like and how do we think about diabetes in a place where there's low HIV presence, but pretty high infection rates of other infections. For example, there's increasing detection. You know, in a lot of places like the Somali region of Ethiopia, there is not a lot of surveillance. So we really don't know HIV, or excuse me, we don't really know diabetes prevalence, but we found pretty interesting data in this very exploratory study that most of the people who were actually diagnosed with diabetes, they had no idea if it was type 1 or type 2. Most of them were very adherent to their medication, and they were often very much underweight. So it provides a very provocative story to understand what is the role of other infections, chronic infection, chronic malnutrition, in how we think about diabetes. It's a very complicated story that requires a lot of future thinking. So why do syndemics matter? Why is it important to study? You know, I look at the lens of diabetes, but you can look at syndemics obviously through the lens of HIV, a lot of other conditions, and there's a lot of work to be done in this area. But why do syndemics matter? It changes the way we think about disease. It inherently requires that we think about the social and the political and ecological and embodied experiences of what it means to have an illness. And what that means in a life. In anthropology, we always say the dichotomy between disease and illness. Disease is objective, and it's found and it's diagnosed, and illness is experienced. Recognizing that diseases rarely exist in isolation. I have never met anyone in my hundreds of interviews around the world that told me they had one problem. It's always messier. It's always messier. And identifying how and what social, political, economic, and ecological factors are driving poor health. We have a new special issue that's open until September 31st, in case anyone's interested, in case anyone's interested, especially you, at looking at how we model and think about syndemics. It's a special issue when you submit to social epi and social science and medicine. Please, everyone submit. But what we're trying to do is really think about how do we test syndemics? How do we test the theory in a really productive way that ends up enabling us to think about what are all of the upstream solutions and what does integrated care look like? How is it financed? How is it organized? How do we invest in it? You know, and for example, what is the impact of taxing sugar-sweetened beverages or having other upstream interventions? Or thinking about universal health care. You know, how do we look upstream and downstream and really thinking about integrated care? I don't really need to go into it. You've covered all of that. But also determining how co-occurring diseases, medications, social dynamics, clinical barriers actually make people sicker. You know, how is it if you actually ask people about their full experience, what is it that's actually making them sick? And you know, at the end of Syndemic Suffering, my first book, I talk about Teresa, who comes in, she has really, really poor diabetes control, glucose control. She's pretty sick. But I asked her, I was like, well, what's your problem? She's like, well, my sister's boyfriend is cheating on her, and my daughter's not doing well in school. And she lists all these things, and they're all social. So it's affecting her. And we have really powerful data, and there's a lot of people, ethnographers, Leslie Jo Weaver is one, who's shown the powerful role of caregiving and gender in where people put money and how they care for their illnesses, from HIV to diabetes to all of these conditions we're talking about. But there are these powerful social dynamics that are at play in why people are adherent or compliant, these words we throw around, or not. Understanding the most effective clinical and community-based interventions to mitigate syndemic interactions, really taking these seriously. There are upstream, downstream, clinical, community-based interventions I have at the end of this talk, but we don't have to look at them. And then recognizing social policy as fundamental as a health desegregation, education, school lunch. These are fundamental health interventions, and really emphasizing the need for people-centered care. I have a PhD student studying care for HIV and diabetes at Bergwaneth in Johannesburg, and it's really, really complicated how people even can go to the clinic, because you have to get work off to go to the multiple, this exists everywhere I've worked, but you have multiple clinical appointments for every condition that you have, which is really impedes you from seeking care for all your conditions. So especially in Nairobi, for example, where you have to pay for diabetes medication, but not for HIV medication, what are you gonna pick? What are you gonna prioritize? Probably your kid's school fees and the free medication for HIV. And that's what people said, that's what we found. And then the idea of syndemics inherently is transdisciplinary, and it's one effort for bringing everyone into conversation. We all have our own expertise and toolbox that we bring to this conversation. Syndemics is one way to be in conversation and try to think of really constructive science-based interventions that are upstream and clinical, and also change how we talk about co-occurrence. Syndemics is implicitly saying that social and political and ecological factors are a part of the story, are a part of how we think about illness and disease. And also cultivating a comprehensive view of how syndemics emerge, converge, interact, and change. That's why it's so important to think about syndemics within one population or another. Diabetes is syndemic in every place I've studied among low-income populations, but it's syndemic differently. And that changes over time. You have to look over time at how it changes. And then also how we study it. Obviously, as an anthropologist, I think ethnography is fundamental in how you build an interview, a quantitative interview guide. But starting in ethnography, moving to epidemiology, and moving back to ethnography. And we're at the epidemiology stage for my first R01. So we've used ethnographic work to build that, and then we're actually moving back to ethnography to test it. So hopefully, social epidemiologists will move in this direction as well. And also taking seriously these complex interactions that are fundamental to understanding these illnesses. So these are some of my colleagues and mentors and partners in all of this work that have influenced my thinking. And then syndemics are not pandemic, uniform, global, non-localized. And this is some work that syndemic scholarship has contributed. So thank you very much.
Thank you.